Good afternoon, everyone, and welcome to the Association of Maternal and Child Health Programs and National Preconception Health and Healthcare Initiatives webinar on the Preconception Interconception Clinical Toolkit. My name is Leah Broadhurst, and I'm a second-year medical student at Georgetown University, and I've been here at AMCHP this summer as an intern with the Women's and Infant Health team. I'm also joined by Megan Philippi, the Program Associate for the Women's and Infant Health team. And on behalf of AMCHP and the UNC Center for Maternal and Infant Health, we're delighted that you are joining us, and we're very excited to discuss this great new resource with you all. So before I get into the specifics of our agenda and turn it over to our speakers, I do have a few housekeeping reminders. Audio is available through your computer, though if you're having any technical difficulties with your audio, please contact Megan via email, and her email is listed on the screen for you. We've reserved the last 10 minutes of the webinar for a question and answer period, and we invite you to submit questions throughout the webinar by using the chat box at the lower left-hand side of your screen. And if you want to address a particular speaker, be sure to include their name in your question. Today's webinar will be recorded, and a recording will be available on the AMCHP website at www.amchp.org. At the conclusion of the webinar today, you will be sent a link to a brief survey via email, and we ask that you take a few moments to offer your feedback, which will help to inform us for future webinars. And lastly, next week you'll receive an additional email that will have the link for the full set of slides and the recorded webinar, so be sure to look out for that so that you can share with your colleagues who may be interested in the information but were not able to attend today. So AMCHP represents state public health leaders promoting the health of America's families through support for state maternal and child health programs, including service for children and youth with special health care needs. And our website and phone number is provided on your slide here. For today's webinar, we have two presenters who were instrumental in the development of the Preconception Interconception Clinical Toolkit, and I'm going to let them introduce themselves to you. First, we'll have Dr. Sarah Verbiest, who's going to provide the background information about the toolkit, and she will then turn it over to Mary Kay Moose, who will take us through the toolkit itself and give us some more information. So without further delay, I am going to turn it over to Sarah.
Thank you, and welcome everyone to the webinar. We are really excited about the interest in this topic and hope to connect with some of you in the future to move this work forward together. So I'm going to start off for just a few minutes and just give you a few resources that are available, and also just talk to you just briefly about the national initiative. So the National Preconception Health and Healthcare Initiative has 4 key goals that we're working toward, and we think it's always good to kind of remember these goals. The first is that we want to improve the knowledge, attitudes, and behaviors of both men and women related to preconception health. We also have a focus on creating health equity and eliminating disparities in adverse maternal, fetal, and infant outcomes. We also are working to ensure that all women of childbearing age receive preconception care services that will enable them to achieve high levels of wellness, minimize risk, and enter any pregnancy they may have in optimal health. And as you can see, the toolkit really fits nicely into this goal, as well as reducing risks among women who had prior adverse maternal, fetal, or infant outcomes through interventions during the postpartum and interconception period, and that's also something that this toolkit addresses. The National Initiative is a public-private partnership that began back in 2004. We have a steering committee and different work groups that you can see on the slide ahead of you. And the clinical work group has really taken the lead on the product that we're going to talk to you about today. But all of our work groups are busy, and so I wanted to just highlight a couple of quick things. I'm not sure if you all have seen the April 2014 MMWR report that came out on the core state preconception health indicators. But this is really quite an important and seminal report in looking at, in some ways, showing a baseline of where we are with preconception health across the country. These slides will be available, so you can click on the link on the screen and easily get to that article. Also, PRAMS has worked really hard to make their data more accessible, and they have highlighted which of their indicators are related to preconception health. So we wanted you to be aware of that resource as well. For those of you that really like to keep up with what is being published in the literature and what is in the news about preconception health, the CDC's Division of Reproductive Health is routinely searching the media and literature on preconception and interconception health topics. And so if you send an email to Cheryl Robbins, and her email is listed on the screen, and ask to subscribe to the listserv, every other week you will get a very easy to read email that will keep you on the cutting edge of what's going on in the field. Lastly, I just wanted to make sure that everyone was aware of the Show Your Love campaign. This has been developed by the Consumer Work Group, and just put on the screen, not going to talk about it in detail, but there's a lot of formative work that went into this idea of how do we talk to women in particular about preconception health. And there are a number of tools and products that were made and tested with the Show Your Love campaign. Two of the most popular were the checklists, one for women who weren't planning a pregnancy and one for women who were. And those are available free for download at the CDC. And there's some other great tools, some videos, some PSAs, some health e-cards. So just wanted to make sure that everyone was aware of those. There's also a really nice implementation toolkit for those of you that want to kind of implement your own Show Your Love campaign. And then finally, we do produce a newsletter that's electronic every other month. And this slide just tells you how you can subscribe to get that email. Again, you can send us an email or you can text us, PCHHC. So again, that's on there, and you'll be able to download the slides and be able to access that information as well. Mary Kay Moose is going to be talking a lot more about the beforeandbeyond.org website, but just wanted to let you all know that in addition to what she's going to talk about today, there's a lot of other resources on this site. So we hope that you all take some time to click around. For example, you can access all of our archived newsletters on the site in the news section. And then finally, as I transition over to Mary Kay, just wanted to invite your engagement on any component of the national initiative. We're always looking for new ideas and new partners, so my contact information is there. If you want us to get in touch with you and you complete your evaluation survey, you can make a note about that as well. So without further ado, I'm going to turn this over to Mary Kay Moose, who is going to introduce the new toolkit.
Thank you, Sarah. I'm delighted to be here and to see so many names of so many people from across the country that I've interacted with over the years. So welcome. What I'm going to do today is, the outline is I'm going to give you the background for the toolkit. I'm going to tell you the design of the toolkit. We're going to talk about next steps and then hopefully have some interactions with your questions afterwards. And this is me, and my email address is there, and I invite you to email me at the end of this presentation if you desire. But I would invite you to make the notes of the questions you would want to ask of me and hold them for 2 weeks, because I'm going to be gone for 2 weeks. And if you send the email, it might get lost in a tumbling pile of unanswered messages. So if you wait 2 weeks, I'll get to it, I'm sure. Thank you. So these are the objectives. At the end of this webinar, I'm hopeful that you'll be able to explain the rationale of why so many people put so much time into creating this. I'm hopeful that you'll be able to go to the toolkit website and that you will be able to navigate and explore and uncover many of the treasures there. And I'm hopeful that you'll be able to identify ways that the toolkit can actually guide practice, including integrating reproductive life planning into healthcare encounters. Now, I just went through all of the slides while I was waiting for this to start, and I realized that the only place where the address for the toolkit is, I think, is on the very first slide. So I'm going to read it to you right now, which is www.beforeandbeyond.org, and that's the address you'll need to get to the website. So when I talk about the background, this work actually started in 2008 when the clinical work group, which is one of the groups that Sarah mentioned to you, the clinical work group undertook investigating the literature around preconception health. We did a systematic review. We looked at 80 different topics, and we graded the topics based on U.S. Preventive Services Task Force grading criteria to determine what elements of care were appropriate to the preconception period. All of the articles are also available at beforeandbeyond.org. So that allowed us to provide a fairly robust review of what's happening in the science. Well, then those of us on the clinical work group were perhaps not surprised but somewhat disappointed that it didn't actually seem, having collected all of the evidence, didn't seem to have impacted clinical practice. People really have many reasons why they were not moving in the direction, and I've listed many of them here for you to look at. But I would say that the two that were most important in terms of not embracing this notion of preconception health was that people don't think they have time in the clinical setting, and that almost universally primary care providers lack appreciation that less than 50% of pregnancies each year are intended. And so generally they would think, well, they would tell us, well, if a woman wants to get pregnant, she can come see me. But as you well know, that would eliminate at least half of the people from getting that content that might provide prevention. So the clinical work group was, as were all of the work groups, was requested to begin a new strategic plan. And in this new strategic plan, several influences came together to make it clear that what we needed to do was to create a toolkit for clinicians in order that they could incorporate the elements of preconception health into their routine care. And some of this background included the recognition that by us, but not by most people, that basic preventive care is in fact preconception care. That those women who eventually conceive, if they've received good preventive care, irrespective of their pregnancy intentions, are going to have a greater likelihood of a healthy pregnancy. That there was also a momentum growing that had started in California in the early 2000s for every woman, every time, as a way to perhaps put before providers this idea that every time a woman comes for care, she should receive a prevention focus. And that was growing. Many states had adopted this mantra. And so we thought that was an important aspect of the environment to encourage us to move forward. There was momentum in helping women find their own voices. I'm sorry, I've lost my place here. I'm using 3 different sets of papers. So every woman, every time is opportunistic care. That means we take advantage of the opportunities that are placed before us in order to provide the care that women need. And I'm not going to spend a lot of time about this. If you have questions, I've written some articles about it, as have other people. But it is taking advantage of the woman presenting and using that opportunity for all that it is worth. More decisions on creating a toolkit rested with the Share Your Love campaign that Sarah just mentioned, and it was really clear to those of us who are clinicians that when we teach consumers something, they're likely to come to their providers with questions, and there is nothing more awkward for a provider than to stand there going, I have no idea what you're talking about. So we felt that this was a way that demand might be created and that this might make the providers more engaged in this aspect of preventive care. Also, there was increasing momentum about reproductive life planning, and we felt that this was again an opportunity for us to engage both women and providers in looking at a new aspect of preventive care. And of course, the ACA suggested that increasing numbers of women were going to be presenting for care, and that with increasing women, we have more opportunity to make a meaningful difference. Now, that we had two resources available to us, one available as we thought about the strategic plan, and the other that came available. The first was the existence of the website, which was devoted to clinical aspects of preconception care. That's the same website that I've mentioned before, and it's the website where you'll find the toolkit. And this website has not received perhaps as much attention as those of us who created it would like, but it has become sort of the go-to place for people who know about preconception health and want to ask questions about clinical aspects of it. One of the things important about the website and that drives traffic is that it offers free CME, and there are modules on there that were created specific for before and beyond. And one of them highlights how primary care and preconception health care intersect. And then we were able to attract some funds from W.K. Kellogg Foundation in order to support a small part of the creation of the toolkit. And this was monies that were awarded to the Center for Maternal and Infant Health to afford several aspects of growth within the Preconception Health Initiative. And we were fortunate to be one of those. Now, our goal in creating this website was to provide a resource that allows but does not require the clinician to dig deep. Everybody who was on the committee to create this was an actively practicing clinician. And every one of us was very, very aware that we did not want people to be turned away because it was too much information. They needed to get what they wanted, what they needed quickly. And so what that required that we do is create a layered approach to the toolkit, that you can go deeper and deeper and deeper as time allows or questions arise, but you don't have to get to the bottom line. We wanted to provide education that weaned them of needing to come to the site repeatedly. This is a little bit like catching a fish and teaching how to fish, and that if they knew the ways to incorporate these prevention messages into the care of women with varying intensity of planning, they would be able to provide the care without returning to the website regularly. So it was not my goal, nor the goal of the committee, that people would come back 100 times. And then we wanted to help providers appreciate that a preconception interconception orientation does not require a great deal of new emphases in their routine care. And so those were part of our design principles. Now, this toolkit is designed, and this is really important, to serve as a resource for primary care clinicians, and I'm probably going to repeat this several times. This is for primary care clinicians, not for specialists, to incorporate efficient, evidence-based preconception and interconception messages and services into their routine care. We had a steering committee that was comprised of clinicians, as I said before, and I've listed the clinicians up here. We designed and created and vetted the content based on the best evidence. We field tested the site and redesigned it based on feedback. Then we tested the new approach and visited focus groups in Arizona, and tweaks were made again to it. And then we sent to the designers, who did an amazing job getting so much content, so many layers of content into a navigable site. This work took 2 years, and it was an amazing committee, all of them extraordinarily busy, and all of them finding time at 5 o'clock in the afternoon, at least every other week, to come together and discuss each other's contributions to the content, to vet them, to talk about design. It was a pleasure. So let me talk a little bit about some of the background on the decisions around the design. What we did not want to do was focus on high-risk women, which I said before, but rather on the majority of women. We wanted to reach as many women as possible. We did not want to frame preconception health as a new silo in women's preventive health care, and some of you have probably heard me speak to that point before. We did not want to create something that would quickly become out of date. Thus, this toolkit is 100% web-based, so we can get online and we can change it quickly. Hopefully people will not choose to print hundreds of pages of this toolkit. It would be difficult to do that because once they do, that's in black and white and could be dated. If they go online, they will be able to see if there have been changes because the content will be up to date. And we did not want to slant the toolkit toward a specific group of primary care providers. So it is not the family medicine toolkit or the OBGYN toolkit or the nurse midwifery toolkit. Here I've listed all of the different kinds of people that are appropriate to interact with the toolkit. And there are a couple of there's at least one I want to call your attention to, which is the office and clinical support staff. This toolkit is designed so that clinicians can empower other people in their offices to carry forward some of the messages and some of the work. And we tried to emphasize that continuously, that this does not have to be a one-on-one interaction between the provider and the patient, but between his practice and all of the different voices in his practice and the patient. There are many opportunities to advance preventive care. We did want to promote assessing a woman's reproductive intention for the next year as a way to maximize the efficiency of a visit. And therefore, the toolkit is based on assessing what the level and likelihood of the woman's intentions are for pregnancy in the next year. For a clinical setting, we are using the one key question, a variant of it from Oregon. Are you hoping or would you like to become pregnant in the next year? And the reply for that then sends the visit into a particular direction. We did want to underscore that the routine assessment parameters of primary care are the same considerations as preconception guidance. So all of us know when we do histories, for instance, there are certain areas that we focus on. And those areas are the same whether it's primary care or preconception health. And I've listed them here. Generally, in the list of primary care topics, family planning isn't listed individually. That would be under reproductive health, but it is so important that we gave it its own heading. Now, all of these topics that are listed on this slide are chapters, if you will, or articles in the 2008 publication that I started with, except for interpersonal violence. And we added that one, though that evidence had not been reviewed because of a variety of reasons, had not been reviewed in the Gray Journal. We wanted to be sure that it was highlighted in this work, so it was added. Otherwise, all of these topics and the evidence behind them are in the Gray Journal. We designed the toolkit to complement the content of routine primary care preventive services. Remember, the number one reason we think people didn't embrace this is they didn't think they had time. So we certainly don't want to give them a lot of more things they need to do. I talked before about the reproductive life plan. And then we included, because we thought people are going to want, if you will, a cheat sheet. so that they can run their eye down it quickly. So there's an at your fingertips that gives all of the highlights of guidance for the 3 groups of women, those who desire pregnancy, those who do not desire, and those who are at risk or ambivalent. And it gives the quick bullets of what are things to stress with each of those women. This can be viewed on the computer, and this is one thing where there's a PDF and they can print the PDF. It also is going to be available on their phones as an app. So for each of the 10 clinical topics, and I gave you that list before, it started with family planning and it ended with interpersonal violence, the clinician can choose to explore various components. The background information, which is the overview of the topic. They can click on clinical guidance. They can click on clinical tools, which is a sampling of tools to help provide recommendations. In all cases with the tools and patient resources, they're but a sampling. And we've tried to make clear these are just examples. There are many more. If we had tried to put forward this as an exhaustive list, the people making the toolkit would have been exhausted, and it would never have ever gotten done. So these are just samplings and examples for them. And then finally, a bibliography. So let's take a minute and look at what the toolkit looks like. This is the home page of the Before and Beyond website, and in the process of creating the toolkit, the entire Before and Beyond website was redesigned and the architecture was changed. So this was a really big undertaking on many levels. And when somebody comes to this landing page on Before and Beyond, they can click at the top for Toolkit, they can click in the middle for Toolkit. There's all kinds of ways that they are going to be led towards this toolkit because it's the newest offering on the site. As Sarah said, though, there are many other offerings, including the CME that I mentioned. So when you go to Before and Beyond, please investigate all the different tabs outside of the toolkit to see what it has to offer. So I hope that this is big enough on your slide for you to see, but once you get to the toolkit, there's a landing page that explains what the toolkit is about, and then on the left side are the key ways to enter into the toolkit. The provider has already been instructed about the one key question, and the response to that key question is going to take them to either the radio button for desires pregnancy, which is green, the at-risk or ambivalent, which is the yellow, and does not desire pregnancy, which is the red. There is a button below that that includes a slideshow and some orientation materials about the toolkit in general, and below that is a tab that you can go to learn more about reproductive life screening. So I've done a close-up of those buttons so you can see them. Now we started with the green, yellow, and red and went, well, maybe that's a little bit too folksy, but when we field tested it, people really liked that, so we stuck with it. Now, if the woman desires pregnancy, the content of the toolkit is going to have extra emphasis on the preconception, interconception content of her preventive visit. So there's going to be more time spent on being sure that, for instance, her immunization status is totally up to date relative to pregnancy beyond her own health. There will be more time spent on the timing of when to conceive. There will be more time spent on more attention directed towards which medication she's taking and whether or not any of them are potential teratogens. Or if she has chronic diseases, how to help her get into the best control in light of the fact that she wants to become pregnant. Now, in contrast, let's say that the woman expresses either ambivalence or she, because of certain circumstances, appears to be at risk for becoming unintentionally pregnant in the next year. There is some preconception and interconception content because she's at high risk for becoming pregnant. But there's extra emphasis built in on family planning and encouragement to deliberately consider her short and long-term pregnancy desires. Again, if they push this button, the clinician is going to be directed to specific recommendations for each of the 10 components of primary care and the at your fingertips, which they can print, which highlights the most general comments appropriate to a woman at risk or ambivalent. And then the woman who does not desire pregnancy, she receives routine preventive care and encouragement to seek additional services if her plans about becoming pregnant change. This is really important because we know life happens. So if, in fact, the woman is visiting me in April and says, no, I don't intend to become pregnant for at least 3 years, and 6 months from now her desires change, we need to be sure that the door is open for her to return to get the most relevant information. So as I said, if you push the button, for each button the provider can choose to review all of the content available by primary care component, those 10, and that would include background information, clinical guidance, clinical tools, patient resources, and references. They can choose to do that, or they can choose to read only the clinical guidance section for one or more components of care, which gives very detailed guidance for addressing a woman's specific needs and risks. Or, as I've mentioned before, they can choose to click the at your fingertips and see the summary statement. So here would be a case where the provider has clicked desired pregnancies, and here is a list of all of the topics that could come up. And he or she will then see across the top the 5 choices: background, clinical guidance, clinical tools, patient resources, and references. And then under background, there are 5 different headings that they can go to. Now, these are what providers would do if they wanted to dig a little deeper. So the scope of the problem. Why are we concerned, for instance, I'll use an obvious one, with chronic disease and preconception health? How many people have how many women of childbearing age have specific chronic diseases would be discussed there. The preconception significance of chronic disease would be discussed under the second heading. Risk identification strategies. Are there ways that have been put forward for identifying which women have special risks or not? For instance, around depression, we have specific tools in the toolkit. Risk reduction strategies, counseling that could be offered. And then at the bottom, important talking points. So if the provider is just going, I just need to know the bottom line, what am I going to say? This is where they could go. So there's many shortcuts depending on their learning style and depending on their personal desires to get the quick messages about what to do to explode the overlap between primary care and preconception wellness. So under clinical guidance, for many of the topics have many subtopics. And for instance, under chronic disease, they are listed alphabetically so that, again, the provider can quickly get to what the provider needs, not have to wade through a lot. Now, it was very important to us before we started the field test, and especially after we did the field test, that people didn't get lost in a morass of options of this toolkit and go, I have no idea where I am. I don't know how to get back to where I want to be. Any of us who've played with websites have had that experience. The designers did a wonderful job of helping people always know where they are in this toolkit. So let me show you how that works. On this one, we can say that at the top we have pushed the yellow button. This is a woman who's at risk and unsure. We're exploring nutrition. We're looking at the background for it, and we are reading about the preconception significance. So we can just really quite easily figure out where we are and how we got there, and can then backtrack our way out if we want to look at something else. Now, I told you about the at your fingertips, and that's an area that I would encourage those of you who are exploring the site to print the at your fingertips so you can study them at some length. We did have a little bit of a challenge with the design of the website of making the at your fingertips look as good on the website as it does on the PDF. The PDF really allows the eye to follow very, very quickly. And it's also something that everybody in the practice could have hold of, could be copied and distributed. So here's an example of the PDF of At Your Fingertips for a woman who desires pregnancy in the next year. This is not to be handed to the woman who desires pregnancy in the next year. This is a clinical toolkit. That we have included patient resources. They're listed under patient resources. This is for the clinical practice to guide them of what kinds of considerations are appropriate for the woman who desires pregnancy. And here you can see under nutrition, for instance, that the BMI is one of the things that should be addressed. Well, any of you who know what the primary care guidelines are for a woman seeking preventive care know that the BMI should be discussed. So we're just helping them draw the line a little more closely about the overlap. So, as the Preconception Health Initiative has gained momentum, primary care providers have repeatedly said they wanted to help make a difference, but they were unsure of what to do. There were other providers, as I said before, who said, we haven't got the time. And there were still other providers who need education that they actually don't know what they don't know. And this came up in the field testing that we did. Occasionally a provider would say, well, I didn't learn anything new as I looked at this website. Actually, that's okay if in fact they're doing it all, but then would go on to declare things that were absolutely not true. An example was a focus group in Arizona where the providers, all except one, declared that interpregnancy intervals didn't make any difference and there wasn't any literature to prove it differently. Well, all of us in public health know that that's not the case, that there's very good evidence that it's 18 months. So it is the ideal interpregnancy interval. So one of the issues that we're going to have now that this is done is how do we reach those who are the laggards, the slow in adopting? How are we going to help them recognize that there is something for them and their patients in this toolkit? And your ideas about that are ones that Sarah and I and others would be happy to hear. So what impact might the toolkit have? Our hypothesis is that tweaking routine primary care services slightly, this doesn't require work as a line I love, is we're not trying to get people to work harder, we're trying to get them to work smarter and teach them, give them the tools for working smarter. So tweaking routine primary care services slightly will result in more women receiving the information they need to make informed decisions about their own health and the health of any future pregnancies. We think that there are a number of potential outcomes. We are hoping by focusing on reproductive life planning and those people who are at risk for an unintended pregnancy, that we can, over time, impact unintended rates. We're hopeful that by underscoring the importance of preventive care that we can improve the general health of women in this country who are of childbearing age. And that improvement will play forward so that by the time they're reaching their older years, their health will be at a higher level as well. We're hopeful that we will have that improved health status and protective behaviors of women when they present for the first prenatal visit will be greater. For example, that more women will be taking folic acid before they become pregnant, or they will not be using known teratogens for chronic diseases, but rather those drugs with the fewest adverse effects for the embryo and the fetus. We hope that this toolkit will help providers think about innovations in their own practice to do more without more time. So as the example I used before of some of their support staff, I often talk about wellness messages on the answering machine when people call in to make their appointments, or having the person who weighs the patient help the patient chart their own BMI. Or one of the things we did here in Chapel Hill was have the receptionist give all of the patients the self-administered depression instrument, which they then completed in the waiting room before they were seen. That there are ways to move away from the white coat and the patient as the only important interaction of the visit. And we're hopeful that we will also be focusing, that this focus is acceptable to women, practices, and clinicians. Now this is important, and in terms of the evaluation, I think we have to remember that there are these specific categories. It may be that the practice loves it, and the clinicians are thrilled with it. And women go, I have no idea what happened in that encounter, but I didn't care for it at all. So this toolkit and what it's putting forward needs to serve the needs and be seen as beneficial to a variety of audiences in order for us to declare it a success. Conversely, the woman may love it, the clinician may love it, but the practice is going, my gosh, we've had to decrease the number of patients we see a day by 3 or 4. Things have slowed down. That isn't an acceptable outcome and clearly would need to be changed. So we really want to look at systems and individual responses. The next steps are to disseminate the toolkit. And my appreciation to AMCHP for sponsoring this webinar, because we're reaching lots of people today to introduce them to the toolkit. But dissemination is key. If we have 500 people here today, each of those 500 would need to reach 500 in order for us to roll this out very quickly. So we need some very strategic dissemination strategies. And unfortunately, we haven't got any budget for dissemination. So ideas, if you have ideas, send them to Sarah and me at the email addresses. I want to encourage people, as we are with you all today, to play with the toolkit. Go in and appreciate what it is and what it is not. Play with it, click around, have fun with it. Because of the way we designed it, we can continue to refine and enrich its content. And that's really exciting. Now, it took us 2 years to get where we are now. And we cannot push the delete button on those 2 years. But there are opportunities for us to refine and enrich while keeping our current navigation. And I am hopeful that over the next while we will uncover specific areas that need that kind of attention. And then to me and many of the people in the clinical work group, one of the most important things we need beyond dissemination is evaluation, and evaluating its impact on those various groups and those various opportunities that I outlined before. Well, it did indeed take a village to create this toolkit. I want to especially acknowledge the members of the clinical work group, and especially the steering committee for the toolkit. as I've said before, it was comprised of very busy and active clinicians who were so generous with their time. And of course, we want to thank Kellogg for providing us some funding, and Sarah's group, the UNC Center for Maternal and Infant Health. Summa Social Marketing gave us, donated to us time in front of focus groups so we could see how our second iteration of this toolkit worked. And then, of course, AMCHP today for sponsoring this webinar. So here I've put some more information. I see when I got to the end of the slides, I did put before and beyond in often for you to look at two of the education CMEs specifically. Preconception care, what it is and what it isn't, for anybody who is kind of going, what? I don't yet get it. I don't know where we're going with this. And then the other one is integrating preconception health promotion into primary care. And both of these are available to you, and if you do need CME, they offer free CME. So now I'm done. I feel like I went through it very quickly, but I really wanted to give enough time for questions and discussion. So I'm going to turn it back over to our AMCHP colleagues who are going to coordinate this.
Thank you, Mary Kay, and also thank you, Dr. Verbees. In the time we have left, we will turn to questions you've submitted throughout the presentation. Please do continue to submit questions through the chat function of the webinar. And so let's go to our questions.
Okay. So we got in a few questions throughout the webinar. First, Mary Kay, one from someone who indicated they're not a clinician but rather an educator. They work with moms during and after pregnancy. Is the toolkit something that she could use during her home visits with moms?
I think she could go on and educate herself, but and then translate that to her patients. However, as a side note, there is a toolkit being created for outreach workers through Healthy Start, which will be available in the relatively near future, and that's really designed for for educating the visitors and then them translating that education to their patients. So that might be a better resource. I don't think that there would be harm in using this as a foundation for education, but if you're not a clinician, you might feel that some of the vocabulary and concepts were not easily accessible to you.
Okay, thank you. That's good information to know. The next question we have is about the list of clinical topics. Is oral and mental health included in the clinical topics?
Mental health is, and oral health is not.
Okay.
There is, in the guidelines section of the website, there is a link to a curriculum on oral health for women, but that's
right.
Not in the toolkit.
But not in the toolkit.
Right, but on the website.
On the website, yeah. And I'll just tell you why oral health did not end up in this, is because at our the oral health for women's preventive health is, I think the evidence is very, very strong that women's health is advantaged by good oral health. The link between oral health and pregnancy outcomes is not as strong, and the articles come out on either side, both sides. That literature has not landed yet, and so we tried to only include things for which we felt there was a strong evidence base.
Okay, great. And this might be an interesting one. What about resources for male preconception health, or like male involvement? Are there any future plans to include those in the toolkit, or any toolkits that you know of for communicating with males about preconception health?
There is in the American Journal of Obstetrics and Gynecology, there was an article about men that looked at what the evidence says about men's health before pregnancy relative to pregnancy outcome. There, in the toolkit, there is often discussions of the couple, not just woman-centered, but couple-centered. I do not think we at this time have great ambitions or energy. That's probably a better word. Energy to add a section on men right now, specifically. But I'd be interested to hear what people have to say with that. We have so much work to do just getting clinicians who care for women. Maybe we should do that well and then turn to the men. The reproductive life planning, though, we do encourage that with that providers who take care of men include reproductive life planning with men. So it's a good question, a waffly answer. Bottom line, we haven't decided to include men yet.
And this is Sarah. I'm going to put the link to the article on preconception health for men into the chat box, but it's found on the Before and Beyond website under key articles in special issues. But I'll go ahead and put that link on the screen.
Thanks, Sarah.
Okay. And just to kind of give audio to this, Sarah's answered this in the chat, but we've gotten a few questions about the toolkit availability in other languages. The toolkit is only available right now in English, but Sarah indicated that is a possibility if there's interest that the work group could possibly look at maybe doing some translation. There was a question specifically about if the toolkit would be made available in Spanish.
Well, now have that person or somebody help me understand how that would because this toolkit is not for the patient; it's for the provider. If the provider's licensed in the United States, I'm pretty sure they have to speak English because I don't know that they have all of the testing available in other languages. So I'm a little bit concerned that question may reflect that I didn't make it clear who the audience is for this toolkit. It's not the patients, it's the providers. Did I understand correctly?
Yeah, I'll see if we have any follow-up in there, but maybe just wondering if there are maybe any particular resources that go directly to patients, which this is not, but I'll monitor the chat and see if there's any further follow-up from that.
This is Sarah real quick. There are some patient resources in the toolkit that are in English and in Spanish.
Yes, yeah, there are, but not the toolkit. It isn't going to be made into Spanish. But patient resources, there are examples of resources that are in both languages.
Okay.
I don't remember, Sarah, I don't think we have any languages other than Spanish, though, do we?
I don't believe at this time. Some of the CDC materials may be in other languages, but I think the key other language is Spanish if we have it up there.
Yeah, I think that's right. But I would, again, underscore that we don't have exhaustive lists of patient education materials, just examples and samples.
Okay. Great. And just kind of a future casting, is this something you guys foresee that clinicians outside of the U.S. could possibly use in the future?
I don't see why not. Provided they can read English. So that would be a limitation. But I know that people from other countries visit Before and Beyond, so they're probably going to tap into this. There's nothing in it that is, there is little in it that is peculiar to women born in the United States. So it is content that would be useful, I'm sure.
Okay.
But our challenge right now, I'll remind you, while we think about all the things we could be doing in the future, the challenge right now is to get it used or have provider awareness of it and familiarity with it in the United States, so that more and more and more women are getting quality primary care, and that primary care will advantage them should they become pregnant.
Do you know of any successes that, sorry, trying to think of the best way to word this. What are some successes with teenage patients? Do you know if this has been used, this toolkit has been used with teenage patients, and any success stories, or is it still kind of too new to tell?
Well, it hasn't been evaluated, so I'm going to give you two answers to this. The broad answer is this toolkit hasn't been evaluated with any population yet. It just came out. This is practically its unveiling. But I happen to be a provider who took care of teenage patients. And so my patients did get, most of them, it was interconception health, and they all got asked their reproductive life plan. And I never had any patient who objected or didn't get it, quote unquote, or wasn't interested in what we were discussing. So I don't think that there is an age at which people who are capable of becoming pregnant should not be exposed to content such as reproductive life plan, and if they're choosing not to use contraception, some important preconception protection for their not yet conceived children.
Okay. Great. And then we had some follow-up questions about the home visiting toolkit or toolkits for community outreach. Do you happen to know a little bit more information about when that's expected out and where that would be housed?
Well, I'm writing it.
Okay.
So it'll be, I'm hoping that it'll be out by the end of the year. It's going to be housed at the National Healthy Start Association, I think. And it's being created in conjunction with, it's a really tight partnership between me as the content expert and representatives of home visiting, the representatives of the Healthy Start home visitors, who are then making sure that the content is relevant to their needs and to their patients. I think it's going to be a terrific resource. We're almost done with 2 of the modules. The first one's called The Birds, the Bees, and the Plan, which has to do with myths around sexuality. It has to do with reproductive life planning, contraception methods, and anatomy and physiology of reproduction. And then the next one is called, I think we've just finished, is called Weighty Matters, and that's looking at weight loss during the interconception period. And this toolkit is specifically written for the interconception period, but the content would be good before any pregnancy, the first pregnancy as well.
This is Sarah, and I just wanted to point out in the chat a comment from Seema Michaels-Dembo, and she highlighted, and I'm glad she brought this up, that the new quality family planning recommendations from the Office of Population Affairs and CDC do have a section on delivering preconception care for men. So, and she put the link on the website as well.
Thank you. That's absolutely right. Yes, and that was just a really important advancement in how we were framing family planning. And the Title X guidelines, I'll remind you, are not just for Title X, were not written just for Title X agencies. They were written as the standards for all providers of reproductive health care. So that's a really important highlight. Thanks, Sarah.
Fantastic. Thank you, Sarah. And I also saw a question, maybe some folks joined late, about where they can access the Preconception Health Toolkit. So I entered into the chat where this is available at www.beforeandbeyond.org is where you can access all the resources in the toolkit that Mary Kay and Sarah have discussed and shared today. We are right at time for our webinar, so I see there's a few more questions in the chat, but we can absolutely pass those on to Mary Kay, and we can get back in touch with you with answers to those questions. So I'll turn it back over to Leah, who's going to close us out.
And if
So
I could,
again,
go
ahead,
I want to
Sarah.
send one word about the billing questions, and we are working with another committee to try to put that on the website at some point. Sorry. There you go, Leah.
Okay, thank you. So again, I'd like to thank our presenters, and I'd also like to thank all of you for attending the call today. We hope you found the information presented to be valuable for your work and that you'll share the information with your colleagues. And I'd like to remind you that you'll get an email to the brief survey, and we ask that you take a moment to offer your feedback. And also look out for an email next week containing links to the recorded presentation and the speaker's slides. So this concludes our webinar. I hope you all have a great rest of the day. Thank you.